Good morning, everyone. My name is Jodi Wolff, and my background is I'm a registered dietitian, and I was in clinical practice for 25 years, and most recently, before coming to Baxter to work in medical affairs, I was able to care for pediatric consumers with special needs, complex medical conditions. And what I learned in my experience is that the caregivers, the consumers, they enjoyed learning about some of the ways to recognize some of these deficiencies. And that's what I'm going to talk about today, is identifying some of the deficiencies, recognizing some of these red flags for vitamin and mineral deficiencies, but also recognizing some signs of malnutrition. Now, I'd like to say that, in teaching this, I found the most effective way to teach this is through some photographs. And some of these photographs are from actual consumers that I cared for in practice. But these may be triggering some of the pictures, especially in the malnutrition portion. And if so, when I get to that malnutrition portion, I just want to be sensitive to that. And if you need to step out or anything, please feel free. My intention is just to share these things so that you know what to look for. So let's jump right in here and get started. So the learning objectives for today, I'd like you to be able to recognize the signs and symptoms of some of the common nutrient deficiencies. So I won't be able to touch on every single nutrient deficiency, but just some of the ones that occur more often. And then identify some of those physical signs of malnutrition, and then learn how to discuss these findings with your medical team. Some ways to, if you do see these, some of these signs, what do you do then afterwards? And so we'll talk a little bit about that today. So what are the causes of nutrient deficiency? And so, this could be for several reasons. It could be that there's inadequate intake. So perhaps your nutritional regimen hasn't been adjusted in a while, or it's just not enough calories or protein for your needs, and it's just inadequate. Or it could be that you're getting a lot of calories, but you're just not absorbing, or the body's not able to utilize those calories. It could be that there's potential shortages, and so you're not able to get the nutrition that you need. And I know several of you have been dealing with shortages with formula, and if anyone's on parenteral nutrition, definitely some of the components of parenteral nutrition. Or it could be that there's intolerance to a tube feeding regimen, or there's severe constipation, or malabsorption, diarrhea, those kind of things that could contribute to some of these deficiencies, or perhaps malnutrition. So some of those losses can cause some of these findings. Additionally, medications can cause some of these deficiencies as well. And so just being mindful of those. And we'll walk through some of those together. We know that some medical conditions are more likely to cause deficiencies, or associated with some of these deficiencies. And so I just wanted to list those. I'm not going to read through this whole list, but really the point with these slides is just to take note that these conditions that have some malabsorption are going to be more likely to result in some of those fat-soluble vitamin deficiencies, which I'll show you some photographs of. Or there's just some conditions where you might see essential fatty acid deficiency from malabsorption, or perhaps it's a condition where there's increased needs just because the body just needs more of a nutrient, or more calories, or protein, or fat because of what's going on with the body. And an example of that would be, a patient, with burns, or someone who has some skin breakdown or wounds. There's going to be an increased need for some of these nutrients. So when we do this exam, and so when I say an exam, this is a little bit different than what your physician might do. It's a nutrition exam. And so, as a dietitian, when I would look at patients, I would look closely at their hair. And some of the things that I would take note of would be the color of the hair, has there been any changes in the texture, any hair loss. And then moving to the eyes, I'd want to take note of any vision changes, and we'll go through some deficiencies that might affect the vision. Any lesions on the white of the eye, what is the color of the lining of the eye? And then moving to the mouth, any cracks or fissures in the corners of the mouth, what is the color of the oral mucosa and the lips? We can learn some things by looking at the nails and the shape of the nails, the color of the nail bed, the texture of the nails. And then in looking at the skin, we're going to take note of the color, if there's any lesions or rashes. And so those are some of the things that I'm going to walk through throughout the remainder of the talk. I think it's really important to note that you can see some of these things and they might not be nutrition related. And so there are other causes. And an example of this, it could just be a stress of illness. And so if there is a bad infection, this can cause a condition that we refer to as telogen effluvium, which is just like hair loss, but it's a result of stress on the body, and it's not necessarily nutrition related. It could be a medication side effect, and so maybe it's a medication that's causing hair loss, and it's not nutrition related. A hormonal change, an endocrine disorder, hygiene-related reasons for, let's say, like bleeding gums, might not be vitamin C, it might be the need to floss more. And so we just want to be careful that, just because you see a physical finding, it may be nutrition-related, and so you want to work with your healthcare team to put it all together. But the purpose today is that if you do see one of these signs is to say, I wonder, is this nutrition-related, and just take it back to your team. So let's jump in here to some of these. And the first one that I'll talk about is vitamin B6 deficiency. And with this deficiency, you may see something called seborrheic dermatitis. This basically, if you look at the scalp, looks like cradle cap. And if you look at the eyebrows, you may see a waxy, scaly buildup in the eyebrows, or there's an area around the nose, and you may see a rash there with a waxy buildup there as well. And with vitamin B6 deficiency, this may be seen with some of the medications, with malnutrition, malabsorption, and so that's just something to be aware of. In looking at the hair and skin, so this was a consumer that I had seen in clinic who was on a very low-fat tube feeding for pancreatitis for a very long time. So she was placed on it in the hospital, and then we saw her for the first time in an outpatient setting, and so she presented with this dry, scaly rash, and it's called scaly dermatitis. And this is seen with essential fatty acid deficiency. So she had the flaking skin, and then she also had significant hair loss. And so her mom described that her hair was just coming out in clumps. And so we knew that day that she was not getting enough fat in the tube feeding. It was only 1% fat. And so we, I talked with her gastrointestinal team and just said, I'd like to, increase her. And so we put her on a peptide formula and then checked her pancreatic enzymes, and then we were able to transition her to a regular formula. And over time, as we corrected her deficiency, then the rash went away, and she ended up, I should put an after photo up here with a really thick little cute bob haircut. And so I think that makes the point that, with repletion, these signs, we should see them resolve. This next picture is a Beto spot. And I've seen these spots on the eyes in some consumers with malabsorption, specifically cystic fibrosis. And these consumers were having difficulty with taking their fat-soluble vitamin or their pancreatic enzymes. And so they presented with lesions on the white of the eye. And these lesions look kind of like a frothy, foamy lesion. And those consumers also had some night blindness, and night blindness is associated with vitamin A deficiency. And so the consumer was saying that she would trip over things in her house in the evening when it was a little bit dark, and had some trouble seeing, and wasn't able to drive at nighttime. And so with this, then we definitely referred her to ophthalmology as well. And I think that, that's really important too. We have, your team that's managing the nutrition, and they have access to all these specialists too. And so when we see some of these findings, especially anything with the eyes, we would also have ophthalmology look just to make sure we weren't missing something. But after replacing vitamin A, these lesions then resolve, and so it's just something to take note of. I'm going to go back because I want to talk about the one on the bottom, because this is a pretty easy one to do, and this is looking at the lining of the eye, and it should be, when you pull down the eyelid, that lining should be pink, light pink in color, and not white and very pale. And so if you see it that it's really pale in color, it could be an indication that there's anemia, and then you'd want to discuss that with your healthcare team so that they can evaluate for potential anemia. The next thing we'll talk about is some findings with the skin. And this first picture on the top is, it's called follicular hyperkeratosis. And that just means keratin coming out of those hair follicles. And you can see this with vitamin A deficiency or vitamin C deficiency. And you can also see this condition on the chest of patients, as well as on the legs and arms. And with vitamin A deficiency, you can see that in malabsorption, and vitamin C deficiency if there's malnutrition and malabsorption as well. The bottom picture is corkscrew hair, and that's where the hair is coming out of the hair follicle in the shape of kind of like a question mark. And it's just not coming out straight like you would expect. And it's known as a corkscrew hair, seen in vitamin C deficiency. This next slide is some pictures of findings with the mouth. And typically, those findings are B vitamin deficiencies. And when we talk about vitamin deficiencies, they often don't occur with just one. There could be several B vitamin deficiencies. And so that first picture of the infant is a pretty severe example of angular stomatitis. But the picture next to it is more often what I would see in clinical practice. And it's just like small fissures or tears in the corner of the mouth that are associated with some of those B vitamin deficiencies. You can also see these with iron deficiency anemia. That bottom picture is a picture of scurvy or a vitamin C deficiency. And this, you can see little hemorrhages on the tongue as well as bleeding gums. And I've seen the vitamin C deficiency in a few patients, and I'll show you some other findings on the skin here in a little bit. Whenever there's a vitamin C deficiency, there's usually some bruising or bleeding that would occur with vitamin C deficiency or vitamin K deficiency. The next picture is magenta tongue, and this is just the color of the tongue, which would be purplish in nature, and this may be seen with B12 deficiency or some of the other deficiencies. Consumers who are at risk for B12 deficiency would be those that maybe you don't have the terminal ileum intact and may require some B12 injections in order to prevent deficiency. Also with B12, it may present as glossitis, which is where the tongue is inflamed or glossy. You're not able to see those taste buds on the tongue. And you can see that in iron deficiency as well as some of those B vitamin deficiencies. That's also a painful condition if the consumer is complaining of any kind of mouth pain, or it may be that there's one of these deficiencies going on. So this picture is a consumer that came into clinic, and he had really bad skin breakdown and had been followed in clinic by a wound team and had some wound vacs at home, and was a patient that needed his tube feeding optimized as well in attempting to kind of work on repleting his nutritional status. And that is his leg in that picture. And you can see that there's little hemorrhages at the hair follicle. It's called parafollicular hemorrhages. And so he actually, when we checked his vitamin C, it was non-detectable. And that day in clinic, because he had all those wounds and because of these physical findings, we didn't wait for the vitamin C level to come back to start him on vitamin C. We went ahead and started him on vitamin C. He also had some findings with the white of his eye was also hemorrhaging. It was very, very red. And his dad thought that he just had allergies, but it was, again, remember vitamin C, bruising and bleeding. It was actually his, like a little bit of hemorrhaging in the eye, and then he also had some bleeding gums. And so classic vitamin C deficiency. When we optimized his tube feeding and replaced the vitamin C, these physical findings resolved, his nutritional status improved, and his wounds began to heal. Because you need vitamin C in order to make skin, make new skin. And so just, seeing that physical finding then was really important in being able to have an intervention. So if you see any of these things, in yourself or your family member, then take that back to the medical team for evaluation. Looking at the nails, sometimes there's findings that are nutritional related to the nails. And so the first one, it's called koilonychia, and that's known as spoon-shaped nails. And so the nail bed should be a nice downward curvature. And if it's curving up like a spoon, then it could be that there's an anemia or iron deficiency anemia. And so I had a little girl in clinic, and her mom said that she was dancing in her sleep. And so she had restless leg syndrome as well as these spoon-shaped nails. And so the literature talks about low ferritins being associated with restless leg syndrome. And so we checked some iron studies, replaced her iron, and then her nails improved, but also her sleep improved. And so that's just a little note there about iron deficiency replacement. That middle picture is splinter hemorrhages, and these are associated with vitamin C deficiency. And so just being aware of that finding would be important. White nail beds may be seen with selenium deficiency, and so that can be seen in patients that have malabsorption or patients on long-term parenteral nutrition. This picture is a consumer that had intestinal failure and high output ileostomy. And we saw her in clinic, and she was just getting a standard amount of zinc in her parenteral nutrition. And so she presented with this rash here around her mouth. But also, she had these blisters that I had never seen before. They're called vesicle bullous lesions, and those are associated with zinc deficiency. When we saw this, we started her on additional zinc in her parenteral nutrition with the next order, but also we referred her to dermatology because, again, we wanted to be sure we weren't missing something else that's going on, because remember, some of these findings can have some other causes. And so they confirmed that it was zinc deficiency, and then she improved as well with additional zinc supplementation. Other things that you can look for in the skin would be the color of the skin. And so something called pallor, which is pale skin, may be an indication of an anemia. And then palmar pallor, where you just look at the palms of the hand. If they're really pale in color, that may indicate an anemia as well. So I'm going to move now to the malnutrition portion, and this is where some of these pictures, are examples of severe malnutrition. And the purpose of that is so that you can see some of the landmarks that we look for when we're looking for where there's muscle and fat wasting. But again, these are some pictures that may be a bit triggering, so feel free if you need to step away to do so. So when we are assessing for malnutrition, we look for fat loss, muscle wasting, and also changes in functional status. So I'll walk through some of those. One of the first places that we see changes in malnutrition is the face. And so taking note of fat loss that may be around the eyes. And if there's fat loss there in that orbital area, which is the eye socket, then that may be an indication of some early undernutrition. With this finding, though, you can also see sunken eyes and those dark circles with dehydration. And so it may not be that it's undernutrition, but rather just the need for additional fluid. And the next area to look for would be around the cheekbones. And so sunken cheekbones may be an indication that there's some fat wasting, or it may just be the person's bone structure as well. And so just taking note if there's been weight loss, but also some orbital fat loss or buccal fat loss, that may be an indication of some undernutrition. Looking at the ribs, and looking at if you can see distinct ribs in the front or the back, that may be an area of fat wasting. And then we look at the triceps, and even though the tricep is a muscle, that's an area we assess for fat. And I don't know if you've seen the skin calipers for tricep skin folds. We will use our finger sometimes in clinical practice and just separate the muscle, the tricep muscle, from the fat, and there should be some ample fat there between the two fingers. And if I take that fold there and my fingers touch, that may be an indication that there's some fat wasting, and so that might be helpful to look at. So that would be what we assess for fat loss. In terms of muscle loss, again, one of the first places that we would see muscle wasting would be in the face. And there's a muscle on the side of the head called the temporalis muscle. And you can feel it if you put your fingers on the side of your head and kind of chew. And you should be able to feel that muscle moving up and down. And if there's wasting there, maybe the fingers will go into a little indentation there. And so that's something to note as well. And then moving down, we would assess the chest muscles and the pectoralis muscle. The landmark that I look for there is the clavicle. And in women, we have more prominent clavicles often, and so that might not be a sign of undernutrition or malnutrition. But if you can hook your finger up under that clavicle muscle, that may be an indication that there's chest muscle wasting. And then you can see the picture there of the shoulders. If the shoulders are really boxy in nature, there should be a curvature if the deltoid or shoulder muscle is intact, and so it may be that there's some wasting if you can see prominent shoulder bones there. The next thing to look at would be the quadriceps, and so the quadriceps, there's 4 muscles in the quadricep. And if there's wasting there in the quadricep, you may see some lines where there's been some wasting there, where it'll look just like kind of like a strip of muscle sitting on top of the leg, and the other muscles may show some wasting. When the wasting is down to the lower extremities or the legs, that's where we may see that it's affecting functional status, which we'll talk about in a moment. Also looking at the muscles in the back is important, and so there's a wing-shaped bone back there called the scapula, and if that's really prominent, it may be that there's some wasting in those muscles that are in the back. And then the calf muscle, that should be, that's in the bottom of the leg in the back, and that should be a really firm, kind of bulbous muscle. And if it's really flat and soft instead of firm, that may indicate that there's some muscle wasting in the lower extremities. So we look for fat wasting and muscle loss when we're assessing some changes in nutritional status. And then when the muscle is affected, oftentimes that's where we see changes in functional status. And so what is functional status? That is different for everyone. So we always just want to get an idea of what the baseline is. And so when we talk about activities of daily living, we want to know if there's any changes in that. Are you having trouble going up the stairs or doing laundry or cooking? Or for children, it would be, are they playing less, sleeping more, not able to go to therapies, things like that. So changes in functional status that are accompanying weight loss may be an indication of undernutrition or malnutrition. So when we talk about these findings, what are some next steps? You definitely want to notify your team and talk, set up an appointment or talk with them. Now, what I learned during COVID is that we learned we can do some of these things virtually. And so we would often be able to have visits. And so that, I don't know if that's something that your teams do, but it might be something that they could take a look at virtually, or they may want to see you in their office. Taking pictures is always helpful in case the finding changes. And so that's really helpful to share photos. I know we looked at a lot of photos during COVID that were sent in to us, and we could actually use those photos. We would adjust tube feeding and then monitor with photos that the families would send, and we could see repletion over time. And so photos are very helpful. Bringing a record of input and output records, and so of, if there's an increase in the number of bowel movements or ostomy output, or that would be very helpful for your team to know when they're looking at some of these findings and whether it could be associated with malabsorption. Perhaps there's something medically that they would change with the plan, or nutritionally. And then just bringing all of your supplements with you to your visit. And that's really important, so that the team can look at, what is the supplement, what is the amount, and this includes all supplements, vitamin, minerals, herbs, anything that you're taking, so that your team can kind of put it all together. Because sometimes, if you supplement one thing, it can cause a deficiency in another thing. And so an example of that would be, maybe there was a zinc deficiency because of really high output. So your team started you on zinc, but then you stayed on it for a very long time, and that ended up causing a copper deficiency or an iron deficiency. And so really important just to bring all of your supplements to your team so that they can do an evaluation. And then if you are started on a supplement for a deficiency, just being sure that you take the entire course and that you follow up, so that the team can see and that you can see that it was effective. Because it could be that maybe they thought you needed a certain amount, but you actually needed more because of absorption, or because of how you were how your body was handling the supplement. So really important to follow up with your team. I know in practice sometimes we would start patients on supplements and then wouldn't see them, and either the deficiency didn't resolve, or like I said, they sat too long on zinc, and we wanted them to not take it as long as they did. And so really just very important to follow up with any of these deficiencies. So interventions, just working with the healthcare team, making sure that your nutritional regimen is appropriate, and that it's meeting all of the macronutrients, so the big nutrients, as well as the micronutrients, because those little vitamins and minerals do a lot in the body that at the cellular level we call them cofactors. And so there are things that we need to ensure that are there for the body to do what it needs to do. And so working closely with your team just to make sure, with tube feeding regimens, your team or your dietitian, if you have a dietitian, can do an analysis of the tube feeding to be sure that it's meeting the daily requirements. And we would routinely do that with our patients, and especially sometimes the needs would be very low depending on metabolism. And if it's a really low calorie tube feeding, then you're going to be at higher risk for some of these nutrient deficiencies. And so, and then it could be that, a lot of times we think we're meeting the needs of the consumer because there's a certain volume, and we say, well, if they're getting at least a liter, then we should be meeting the needs. That's not necessarily true. It's very individualized, especially in conditions with malabsorption or if there's increased needs. And so have your team, ask them, hey, have you looked at my tube feeding regimen, and is it is it meeting all my needs, not just my calorie and protein needs, but my vitamin and mineral needs? And there's programs where they can do that really quickly. Plug in the tube feeding and the amount, and it'll show if they're meeting the needs. So that's one thing that may be helpful. And then working closely and communicating with your team in times of shortages, and I know that many of you have had to deal with those, and so just staying in close contact with your team during those times. If there's any changes, intolerance, working closely with your team to correct the root problem, because I know that affects the ability to get in your nutrition for that day if you're not tolerating it or not able to get your total volume in. So that's something your team would want to know, because perhaps they would consider changing your product or changing the volume or the regimen. And the last thing is, just being sure that your quality of life in terms of the schedule for your for the nutritional regimen is working for you. Because a lot of times, I worked in both the inpatient setting and outpatient, and patients, consumers would go home on regimens that worked really well for the nursing staff, where there's 24/7 care. But then, they get home and, if a tube feeding is running over an hour, every 3 hours, then that's a very, very long time and not very manageable for home. And so we just want to be sure that it works for you. But I'm going to wrap it up here and allow some time for questions. So thank you. And if there are any questions.
I'm on enteral feeding, Jodi 1.2 since September. I take 8-ounce cartons a day as my sole food of nutrition. Am I missing anything, like any kind of something? Should I take a multivitamin once in a while or anything else to supplement that Jodi, what it provides?
Yeah, I would definitely talk with your healthcare